Recording in progress.
Hi, Assalamualaikum warahmatullahi wabarakatuh and good afternoon. How are you guys doing today? Are you guys ready for your MEDEX preparation? I am Suhana and I will be your moderator for today. On behalf of my MEDEX team, we would like to welcome all of you, speakers, participants, doctors and colleagues to our virtual course, and thank you for carving out your time today for participating in our event. For your information, My MEDEX Academy is a platform to educate and disseminate knowledge on health, medicine, and surgery. We strive to train medical practitioners, encompassing house officers and doctors, medical assistants, nurse, medical students, to be more knowledgeable, competent, and safe in their professional healthcare journey. So to date, we have impacted more than 3,500 individuals from medical community through our physical workshop, conferences, webinars, seminars on different medical skills like circumcision, surgical, episiotomy, contraceptive, postgraduate pathway like MEDEX, parallel pathway, and all lah. And our circumcision center regularly holds prenatal event, okay, like berkaitan event lah, right? So let us officially start today's session to a brief explanation about our esteemed speaker for the day, Associate Professor Dr. Muhammad Zulfaqar. All right, he got his MBBS from IIUM and also Master in Medicine from USM. He was also the Chief Examiner for Pharmacology in Anesthesiology and Intensive Care Primary Examination in last year. Okay, he experienced as a pharmacology examiner since 2018. So, I urge everyone to make the best out of today and ask all the questions that you want, okay? Because this is the guy that you want to ask. So, some housekeeping notes. Feel free to raise your hand virtually if you have any question or you need clarification, or you can type them in the chat box and we will get you sorted out. So, I highly encourage and request all participants to keep your videos on so doctor can see your faces and we can all engage with each other. So this is semi-formal setting. So don't be quiet and timing. It's your time to gain as much as you can. So there will also be a such session of mock exams. So you whip out your wits and answer well. And then we will have a discussion on the answer afterwards. So without further ado, I would like to welcome our speaker to get the ball rolling. The floor is yours, Doctor.
Okay, Assalamualaikum and good evening to everyone who joined the MEDEX Anesthesiology preparation exam. And before I move on to the next slide, thank you for the nice introduction by our chairperson today, My MEDEX Academy, Suhana. And before we move on also, I just want to know whether my voices, is it clear? And can you all see my first slide, MEDEX Anaesthesia 2024? Okay, as we mentioned just now, my name, Dr. Muhammad Zulfaqar bin Mazlan from the Department of Anesthesiology and Intensive Care, School of Medical Sciences, University Science Malaysia, and zulfaqar@usm.my is my email, just in case at the end of the session or after the session, you want to ask a question or want me to clarify, right? You can just email me. I will try my best to answer your question. I'm sure that all of you who joined today will be sitting for the next MEDEX Anesthesiology exam. And if you pass that exam or be in the best 100 or 120, depend on the number of the students that we are going to enroll for the next Master of Medicine, I mean next year. And the best among the best will be choose, right? So you need to score for this MEDEX Anesthesiology exam, and together with your carry mark assessment by HOD and then by other point that I will be highlighted after this, and altogether you will maybe get 100%, which is impossible. Maybe you can score 80 or 90%, and that score, maybe you are in the top 100 or top 120. Usually the intakes, if around, I think around 100 to 120. I think for the past a few years, 120, which we share among the 6 university. So University Malaya, I think the highest, I mean, in terms of the enrollment, maybe around 30 to 40, followed by USM, UKM around 25 to 30, and the rest by UIA and UPM, maybe around 10 to 15, and the last university, I think, who just joining the conjoined, I think University UITM, which is, I think the enrollment, I think past year, I think around 6 to 8 candidates. So altogether becomes 120. And for your information, I think anesthesiology is among the highest, I think, being offered HLP from the Ministry of Health for the past years. I think among 800 and 120, I think belong to the anesthesiology. But of course, the number keep on changing depending on the situation, and then the scholarship from the Ministry of Health. And of course, you also can pay. I mean, you can pay by yourself. I mean, if you want to join the Master of Medicine, if you are past the MEDEX Anaesthesia. So without further ado, I will move on to our next topic or next outline of the presentation. I'm going to talk about distribution of marks a little bit, and then the scope of topics, I think very important for all of you to pay attention, because a lot of things that you need to read, pharmacology and physiology, and you need to strategize what are the topic that being chosen by the committee that we think that this is the important topic need to know for the entrance exam, MA anesthesiology, and format of the question as well. You must know, is it multiple true false? Is it A, B, C, D, the choice? Is it one best answer, single best answer? What is that? And I will share with you example of question that related to the physiology and the pharmacology. Okay, we move on to the format. Last 2 years, I mean in 2022, the format consists of 60 questions, single best answer, which account for 60%. And the rest, 40%, the mark from the head of departments, anesthesia experience, your SPM level or your SPM certificate results, service in the Ministry of Health, district rural posting. Last year, the format changed, and if you can see, 15% increase in 60 question SBA MEDEX exam. So 50% increase from 60 to 75, meaning that very, very important to all of you to score the MEDEX exam. And 25% account for HOD marks, head of department, anesthesia experience, no more SPM. So even though you fail SPM, I don't know. That one is just joking, right? I'm sure if you fail SPM, you are not in the medical doctor from the beginning, right? Service in the Ministry of Health and district rural posting. So altogether 100%. So let's say we have maybe 100 application and or 200 application. So after the MEDEX exam, you got maybe 75% out of 100. So maybe you got 60, right? Out of 75 full mark, plus the mark from your carry forward from your experience, head of department, right? You got 20 or maybe 15. So when you add together, all together maybe around 75 or 80, for example, right? And if your mark is within the best of 120 that the university wants, so you will be allocated to the 6th university. So you will not know whether, even though you want to go in USM, even though you want to go to UIA, UITM, UM, so randomly, usually you will be placed. Of course, there will be appeal later, right? That one is different story, right? Okay, next, how about the details, right? Of the carry forward marks. 10% from the anesthesia experience. Let's say you have 5 years, maybe 2 marks per year, then 5 years become a 10%. You got full mark. HOD or head of department report, you are very good in your department. I mean, your HOD also recognize you, your works, maybe your mark is 9 or 10 over 10, and you got 10%. And service in the Ministry of Health, for example, right? Maybe you got a 2-year service or 3-year service, and then you will got 2 mark or full mark for that, but altogether only 2% will be calculated. And the other thing is that if you are also service in the district or rural posting, which also can give you around 3% mark. So that's all the carry forward 25% and plus 75% from your MEDEX examination. Out of this 60 single best answer question, 30 from the pharmacology and 30 from the physiology question. Now we move on to the topics. Physiology 30 question, pharmacology 30 question. A lot of physiology topics, a lot of pharmacology topic that you need to read if you open the physiology textbook in anesthesia and pharmacology textbooks in anesthesia. But for entrance exam, I'm just want you to focus on these core topics, such as cardiovascular, respiratory, renal, and central nervous system. So you try to focus these 4 main topics. And out of these 30 questions, majority usually the question from the cardiovascular and respiratory. So maybe the question between around 8 to 10 question, or 7 to 10, or 9 to 11, but just around that, right? And the respiratory question as well. The renal question and the central nervous system may be less priority compared to the above systems. But it also carry about 5 questions for each of the system. So altogether 10 questions. And for the 30 question pharmacology, the scope of the topics also around the core topics, such as IV in anesthetic agent, inhaled anesthetic agent, analgesic, local anesthetic, LA, muscle relaxant, or reversal of neuromuscular blockade. And all together, they share the question and distribution maybe around 3 to 6, 4 to 7 question, or 4 to 6 question. So all together become 30 question, 30 pharmacology and 30 physiology question. Maybe all of you want to know what are the textbook in physiology. If you don't have, you can buy this textbook. Principle of Physiology, Peter Kamp, or Linda Costanzo, Physiology. Or if you want to read more question and answer, you can read the Physiology Viva question and answer by the Carrie Brandis. And if you want to read more or detail or to get more understanding, you can read Vast Respiratory Physiology, or known as J.B. West, or you want to read Levinsky, Pulmonary Physiology. I think that's 5 books is already enough. Of course, if you don't still difficult to understand, you can just Google and try to ask information or search the information in the up-to-date. Up-to-date is one of the online or reference that usually the doctors or lecturers will try to inquire all the details about the topics, because in that up-to-date or www.uptodate, they will gather all the latest or the current evidence. Maybe not suitable for the entrance, but maybe some of the explanation will help you. So, but of course, up-to-date, you need to log in. Only free, I think, if you are in the university, some of the university, they log in, and the benefit all of the student, usually they can log in free during the year of study in the university. Okay, what about the pharmacology textbook? I would encourage you to read the Stolting Pharmacology. So I think now maybe 6, 7 edition, right? So this is not the latest, but the knowledge more or less the same. You can refer to the new one, but not much changes. And I would encourage you to read in the Stolting all the core topics that I'm highlighted just now. And if you want to read in the simplified form, you can refer to the TE pack later. So some of the information in the TE pack, some of the information in the Stolting. So you can complement each other by reading these 2 textbooks. Of course, if you want to know more details, or you want to inquire more knowledge, or maybe some of the knowledge is not in the TE pack book or Stolting, you can try to have a look at the Akinhead textbook of anesthesia, or Morgan Michael of anesthesia, clinical anesthesiology. So these 2 textbooks also more towards the clinical, but maybe some of the question, the core topic, maybe you will get answer here. Of course, this is the textbook of the anesthesia. I think 700 to 800 ringgit. If you want to buy this textbook, right, you can just buy via online or in the, I think, Shopee. I think a lot of textbook now available in the Shopee. You can just buy, and then this is, I think, yeah, if you have money, you can buy, right? I think it's good if you want to know, or if you want to get more information, and that information is not available in the books that I mentioned just now. So remember, please read this textbook. And what about the physiology? Basically, the question, we want to make sure that you understand the basic physiological, the knowledge that you can apply whenever you practice anesthesia and critical care when you are enrolled in the master program. So we want to know whether you have some basic understanding or not. So the question is not details, is not complex. It's just a basic physiological knowledge around the core topics that I mentioned just now. Let's move to the cardiovascular question just now. Among the question that being asked for the past year, usually they will ask either cardiac action potential, cardiac cycle, preload, afterload contractility, Frank stalling mechanisms, electrical activity, and autonomic innervation. What about the respiratory? If you look at the J.B. West and Levinsky respiratory textbook just now, you can read and try to focus on these core topics: control of breathing, lung volume, lung and chest wall compliance. Sometimes if you read one textbook, you didn't get the information that you want, you try to refer to the Peter Kam, and then try to refer to the Linda Costanzo just now, or Carrie Brandeis, or try to search in the internet, and you try to understand in the way that you can understand better, because some of the information or some of the sentence will make it you confused. But whenever you try to have a look and compare among the textbook that I mentioned just now, I'm sure that you will get some information that you want. Word of breathing, oxygen and carbon monoxide transport. So you try to search for this topic. And one more thing now, if you can register, artificial intelligence now, ChatGPT, you can just, type this topic: control of breathing, lung volume, lung and chest wall compliant, right? So you can just compare. Because artificial intelligence, they also get the information from all the reference that available in the internet, sometimes from the source that reliable. So when you read the textbook and then you read all the sources that I mentioned just now, and you want to understand better, I think it's not wrong, you just type in the ChatGPT, you can maybe understand better, right? Okay, surfactant, west zone, pulmonary circulations, causes of hypoxemia, I think very important, either because of the hypoventilation, a diffusion problem, shunt, ventilation profusion mismatch, right? These are all the topics that you need to cover in the respiratory system. So I would recommend you to read the J.B. West. If you don't understand J.B. West, you can refer to the Levinsky, and then you can read the Carrie Brandeis. I think one page per section or per topic that I mentioned in the Carrie Brandeis. Maybe some of them is not available in the Carrie Brandeis, such as the West Zone. Yeah, I think the West Zone is not mentioned very detailed, but if you read J.B. West, very detailed about the West Zone of the lung, right? So try to understand. Renal, try to focus on the glomerular filtration rate, electrolyte handling, acid-base handling, renal response to hypovolemia, and a little bit about counter current mechanism. And yeah, this is not the easy topics, right? You need to read Peter Kam, and then Carrie Brandis, and then try to read Linda Costanzo. And after that, maybe you can compare in the internet sources whether it match or not with your understanding in the textbook. Central nervous system. So try to read about these 5 core topics. So there will be one question, I think, from this core topic that I mentioned just now, and altogether will become 30 question physiology. So dynamic and metabolism of cerebral spinal fluid, intracranial pressure, blood-brain barrier, cerebral blood flow, and sleep physiology. Now, you already know the core topics in physiology and the section in the core topic that you need to read and understand. So please try to focus on the topic that I mentioned just now. So most of the question will be around that core topics. We will not ask you the question that very detailed. I mean, not in that core topics. Maybe 1 or 2, 3 questions a little bit deviated, but I can say that majority is based on that core topic that I mentioned just now. So we move on to the pharmacology question. Another 30 question, and the same principle or the we need you to understand the basic knowledge of pharmacology concepts and the drugs used in practice of anesthesia and critical care. So for this purpose, we try to ask you only the core topic in pharmacology. As I mentioned just now, inhalation agent, IV anesthetic agent, local anesthetic, muscle relaxant, and analgesic. Right, that is the 5 core topics. Maybe you want to know the subtopic from the anesthetic agent. Very difficult in pharmacology because in physiology you can just list the topic, but in pharmacology such as IV anesthetic agent, you must know the classification, mechanism of action of the, for example, 5 drug that we have. Propofol is the most common now, so you have to know the mechanism of action of propofol, the mechanism of action of ketamine, the mechanism of action of midazolam, mechanism of action of etomidate, and the mechanism of action of thiopentone. So please read the Stolting. Only in the Stolting, the detail about the mechanism of action. If you read other textbook, maybe very difficult to get that. So at the end of this course, I want all of you open the Stolting and try to make a note regarding the mechanism of action. So sometimes the word is a little bit deviated. I mean, a little bit try to disturb you. For example, GABA A receptor, gamma receptor, alpha receptor at the GABA, right? Most of IV anesthetic agent, usually they will add on the GABA, right? But you have to know the GABA receptor, whether they inhibit or enhance the GABA, right? Or they directly cause the receptor to be activated, right? That one, the statement only in the Stolting textbook. So I want you to read line by line. Open the Stolting and then you go to the page, for example, midazolam, and then you write, oh, this is the mechanism. Oh, a little bit different only, for example, just This one GABA, this one enhance, this one bind to the receptor, for example, right? So sometime in the SBA, at one glance, you thought that this is the true, right? But when you read a second time and when you remember the Stoltin page, what page, for example, then you will know whether you are wrong or not, right? Ketamine, for example, a lot of mechanism of action of ketamine. Maybe you just know an MDA receptor, but for your information, there will be another 7 mechanism of action of ketamine that you need to know, right? So all in the one paragraph, I think 1 or 2 paragraph only in the Stolting textbook, right? So remember to get the Stolting textbook. I think if you have the PDF from your friends, right, which buy the textbook, you can ask your friend to share, or maybe you can just buy from him or from her, right? It's just that you want to make your own notes, right? Please, I'm just want to share with you, if you are ready to go to the entrance exam, for me, when we talk about IV anesthetic agent, you will remember what page. Oh, Tiopenton in page, for example, 341 on the right side. Ketamine, for example, 350. So you can imagine this is the mechanism. That is how. So 5 mechanism of action, try to go and have a look the detail in the sorting. Indication and contraindication of that drug. So of course, in anesthetic agent, the main indication is for anesthesia, right? A little bit contraindication, such as those who are having porphyria, or those who have asthma, right? Those who have increased ICP, for example, you can use the ketamine, right? But uncontroversial, sometime in a short period, sometime during the hypotensive episode following trauma, for example, BP low, you want to induce. So you will try to use the ketamine, for example. But if you know the head injury and GCS is low, for example, maybe some element of increased ICP there, try to avoid, for example, ketamine, for example. And if you have patient with hypotension, for example, try to avoid using propofol, for example, right? Because propofol is the most among the 5 anesthetic agent that can cause drop in blood pressure. If you have asthma, for example, maybe you want to choose ketamine because of the bronchodilation effect of the ketamine, for example. And if you have the heart disease, for example, you want to try intermediate, for example, right? Because intermediate being studied that not much cause in blood pressure whenever you give, but of course you need to monitor as well, right? By arterial line if you want to induce high risk cases with intermediate, because sometimes it also can cause a minimal drop in blood pressure. Pharmacokinetic. After you know about the mechanism, indication, contraindication, classification, either barbiturate or non-barbiturate, you need to know a little bit about pharmacokinetic of each of the drug. For example, ketamine, for example, administration, the distribution, metabolism, and excretion. So you must know whether this is active metabolite or not, right? Excreted in the kidney or in the liver, propofol, thiopentone. So how this drug, when we give intravenously, add in the brain, and then after that metabolized, distributed, for example, either in the fat tissue, those who are highly lipid soluble. And pharmacodynamic of the drug, mainly about the effect of the drug to the CNS, cardiovascular, and the respiratory. So I think these 3 main system, pharmacodynamic, you need to know detail about the the 5 IV anesthetic agent that I mentioned just now, and the adverse reaction of each of the drug. For example, propofol, hypotension, bradycardia. But the good things about that, for example, indication of laryngeal reflex, right? Thiopentone, for example, the dose compared to the propofol predetermined, meaning that if you give 5 mg per kilo, for example, 250, you can, for example, be sure compared to the propofol, whenever you want to intubate, patient will sleep. I mean, faster compared to the propofol, compared to the other drug, which takes variation a little bit. When you give the dose 2 mg per kilo propofol, for example, right? Ketamine, 2 mg per kilo, for example, right? So sometimes it's not that as good as thiopentone for that reason. But for the other reason, the most ideal properties, I think among the 5, I think propofol, right? And propofol also being used for the TIVA, right? Total intravenous anesthesia and the target control infusion. Inhaled anesthetic agent. Remember about the indication, contraindication, and the most common inhaled anesthetic agent that we use nowadays, which is the sevoflurane. So please make sure that you read detail about the sevoflurane in the Stoltin and TEPAC. And after that 2 books, maybe you can refer to the other pharmacology books, such as Miller, Akinhead, or the Morgan Mikael just now. Right? And the next drug that you need to highlight or need to be focused is the desflurane. Right, sevoflurane and desflurane are the main 2 inhaled anesthetic agent that been used, I think, in almost all the university and the Ministry of Health hospital. Previously, we use isoflurane, and maybe some of the hospitals still using the isoflurane. And for the past 30 years, I think your generation and my generation, I think we no longer being exposed to the halotane, for example. But if you go to the third world countries such as Bangladesh or other countries, still they are using the halotane. So maybe you need to know a little bit, right, about that drug. But please be highlight that sevoflurane, desflurane is much more important. And if you already understand that 2 drugs, and you can just have a look also the inhalation and the agents such as the isoflurane and the halotane. Mechanism of action, you must remember how this drug acts. So you must remember about the partial pressure of the inhaled anesthetic agent from the circuit, from the vaporizer. When you on, right, they will travel through the flow that you set on. The higher the flow, the higher the inhaled anesthetic agent will go into the alveolar or into the alveolus of the patient through the EDT, through the breathing circuit. The higher the concentration that you dial, the higher the drug will be going to that alveolus, right? And the circuit also very important. The circuit of the inhaled anesthetic agent. Ideally, you must design the circuit that non-absorb, meaning that when the drug travel through your circuit, breathing circuit, that breathing circuit, if you can design the material that something, 100% from prevention for absorption. So that one is much more, better, right? But of course, with some limitation, we can't really, sure that whether this is 100% prevent reabsorption or not. The next thing, when you dial, for example, 8% compared to the 2%, of course, 8% is more. And whenever the flow is more compared to liter and 15 liter, right? The circuit, which one is it the smaller circuit or the larger circuit we want, right? For example, right? Which one will cause more partial pressure in the alveoli, for example, right? The next thing, the volume will travel through the flow that you set to the alveoli. And then whenever they reach the alveoli, they will create some pressure inside, or we call it the A capital letter of A, which is the pressure in the alveoli or alveolus. So the next thing, you have to know the pharmacokinetic of each of the inhaled anesthetic, the four inhaled anesthetic that I mentioned just now. You need to remember the blood gas partition coefficient. So whenever the drug in the alveoli, there will be some of them will be absorbed into the circulation. So that's one we call it solubility. The more soluble the drug, the less rapid the onset of that drug. For example, if you want to compare halothane, for example, and you would compare the sevoflurane, which one do you think that will give you faster onset? So this is the concept of blood gas partition coefficient. Because you must remember the one that give the action is not the concentration that travel in the blood and then reach to the brain, like you are giving the propofol or you giving the furosemide or Lasix go to the kidney, for example, right? When we talk about the inhale, the mechanism of action actually based on the partial pressure. In order to develop the partial pressure in the brain, there must be equilibrium between the alveoli. Alveoli already full, then they will, for example, create partial pressure in the PA, a small a, and whenever the pressure in the small in the circulation is already full, then they will transmit into the brain. That is, we call it the pressure PB, right? So in theory, the more soluble the inhale, difficult to create this partial pressure because they will keep on distributed and then diluted, for example, right? So they will keep on, the drug, we need more from the alveoli, and the alveoli also will distribute, so they cannot maintain inside the alveoli because of the solubility, right? So the less soluble the drug, or the smaller the blood gas partition coefficient in terms of the number, for example, 2.4 and 0.7, 0.5, for example, which one is less soluble, right? Of course, the one that small number, 0.4. So that is another reason that you have to know. Of course, the mechanism of action, you need also to remember a few theory. They will go to the membrane theory, the GABA receptor as well. The pharmacokinetic, as I mentioned just now, the factor that faster the onset and the slower the onset of the inhaled anesthetic agent. Pharmacodynamic, meaning that what this inhaled anesthetic agent will cause effect to the central nervous system, cardiovascular, and respiratory. This is the main core topics effect that we want if you study the inhaled anesthetic agent. An adverse reaction, for example, CNS, we want to know whether what was the effect to the cerebral blood flow, ICP. You give ketamine, you give the inhaled anesthetic agent up to 2 mg, for example. Is it increased ICP or not? In principle, if you give inhaled anesthetic, as long as not reach more than 1 mg, there will not much significant in terms of increased ICP. But if you use more than 1 mg, then there will be increased ICP. For example, this is the pharmacodynamic in the brain, for example, right? For the CNS, central nervous system. For the cardiovascular, it is concentration dependent. For example, the higher you dial the inhale, the tendency of the hypotension also is there, right? Compared to the minimal dial of the concentration. Analgesics, pharmacokinetics, and physiochemical parameters. of the opioid analgesic, mechanism of action of opioid. Mechanism of action, I think you need to remember that how many opioid that you know, how do you classify the opioid, for example, right? You can classify the opioid based on the potency or based on whether this is strong opioid, right, moderate, or you can classify into the traditional ways such as the synthetic, the natural, or based on the receptors such as the full agonist, partial agonist. So this is a classification that usually being asked and being tested in the exam. And sometimes they can just put the definition of what is the difference between opioid and opiate, for example, right? Just asking you in the statement about definition, right? And adverse reaction of opioid, I'm sure that you can read about the central nervous system effect, for example, sedation, go to the lung, for example, bronchodilation or bronchoconstriction, mainly, right? Opioid, right? Which one that least histamine release that can cause bronchoconstriction if you compare a morphine and fentanyl, for example, right? And then constipation in the GIT, sedation in the central nervous system, hypotension, bradycardia in the cardiovascular system. These are the effects. If you are given intrathecally, acute urinary retention, pruritus, for example, nausea, vomiting, GIT. This is the things that you need to differentiate. Try to differentiate between the fentanyl, morphine, right? And some of the opioid, mild, not the strong, which is the moderate or the mild opioid, such as the codeine, tramadol, right? Fentanyl, of course, is strong opioid. Morphine, strong opioid. But you need to also know about the less strong opioid, such as pethidine, a little bit, right? And then pharmacokinetic and physicochemical properties of the non-opioid. So how do you classify the NSAID, cyclooxygenase pathway inhibitor 2, for example, such as paracoxib, celebrac, right? And Voltaren, for example, the classification for the NSAID in the group that not the same as the celebrac and the paracoxib. Adverse reaction of the NSAID, which is common, such as the GIT bleeding, right, for example. Then we move on to the LA classification, structural activity relationship. Sometimes you need to remember also the chemical structure. So of the LA, for example, ring structure of the bupivacaine, ropivacaine, and levobupivacaine or the lignocaine. This is the 4 main LA that being asked and tested, and we use every day, right? So you try to just have a look, right, about the structure. How do they differ among the 4 LA just now? Classification, whether ester and amide, and between the ester and amide, for example, what are the advantages? Which one is more rapid onset, last duration of action, I mean prolonged, metabolized to the more component that can cause hemoglobinemia, for example. Is it the ester? Is it the amide? And then what are the LA that we use nowadays? For example, our EMLA, right, consists of what? Eutectic mixture of local anesthetic. So you have to know the combination of that, whether this is a ester or amide, and try to differentiate both of them and with some of the example, because sometimes in the exam you are confused whether this is amide or ester, right? Of course, if they ask about the bupivacaine, liver bupivacaine, and you are quite sure that this is the amide, for example, right? And cocaine is a ester, but what about the prelocaine, procaine, and then you start to confuse, right? So try to go for that and just remember if it is come out, so you are not confused in the exam, right? Mechanism in general, they will inhibit the sodium channel. How? They will inhibit, they will try to dissociate into ionized and non-ionized. And non-ionized, which is the lipid soluble, will travel into the cell inside the cytoplasm. They will bind to the receptor, which in the phospholipid bilayer membrane. But they will bind whenever they enter into the cell, right? So the one that bind, then they will further differentiate into ionized and non-ionized, right, inside the cell, right? And pharmacokinetic, about the ADME, administration, metabolism, distribution, and the excretion of the LA. Pharmacodynamic, the most very important, I think you need to know about the side effect of the LA, or we call it the LA toxicity. What are the earliest symptoms of LA toxicity? For example, you give the regional anesthesia every day in your practice, and the patient start complaining of what to indicate this is the earlier sign. For example, meningitis, perioral numbness or tingling sensation, for example, right? And then after that, followed by what? Is it the cardiovascular or CNS? Is it hypotension first or is it fitting first, right? Start to fit and then arrhythmia and then arrested, for example. You try to go for the lignocaine table, because I think the one that been studied on lignocaine. So how much lignocaine? Which equal to this symptom, for example. I think very nice in all the textbook, there will be a table to indicate the LA toxicity. And the muscle relaxant, how do you classify the muscle relaxant? Whether based on the duration of action, such as ultra short, short acting, long acting, such as pancuronium, right? And rocuronium, atracurium, and mivacurium, cisatracurium. This is the classification that you need to remember. And classification also can be in the form of the depolarizing or non-depolarizing, such as scoling depolarizing, non-depolarizing, rocuronium, vicuronium, right? And the other. Mechanism of action, this is very important as well, right? Mechanism of action, the drug will travel to the presynaptic and then postsynaptic. Whenever there is a neuromuscular junction there, bind to the acetylcholine receptor, block the acetylcholine from binding to its receptor, and no action potential be generated. But remember, they also can inhibit the pre-receptor in the presynaptic nerve, right? Which reduce the acetylcholine, right? Inhibit acetylcholine from the vesicle to be released, right? So this is among the mechanism, right? And if you understand this mechanism, you will understand how the neostigmine act. Neostigmine act indirectly by inhibit the enzyme in the acetylcholinesterase that try to break the acetylcholine, right? So whenever there is no acetylcholine breakdown, you must remember that acetylcholine will be increase, and they will compete, and they will be chance they will bind to the receptor there, right? That is indirect mechanism, right? Compared to the sugar MEDEX, they goes into the blood, they will engulf all the what we call the rocuronium inside the blood vessel, and where they engulf all these, they will create the concentration gradient, meaning that less in the blood but more in the neuromuscular junction, synaptic cleft. Then this all the muscle relaxant will be redistributed into the circulation bed. And then there will be less and less concentration in the synaptic cleft, and there will be no more the muscle relaxant. So this is the concept, direct and indirect, right? Sugar MEDEX, right? Pharmacodynamic, the muscle relaxant, how the effect of this drug to the central nervous system, cardiovascular system, and the musculoskeletal system. And a little bit with the monitoring TOF. I think at the end of the slide, I will touch a little bit about the TOF and reversal of neuromuscular blockade, how it's relate each other. So now we already 1 hour about the explanation about the core topic. I hope that you are not boring. Of course, now we move to the interaction session. The format of the question, single best answer, or SBA format of the question. And I hope for the last 1 hour, you will get some information how to reach your textbook after this, right? So how to focus. I can't teach you that in that 1 hour all the topic, because if I want to teach you for 1 hour, I think nobody will know. I know if you can, be taught by that 1 hour, I think all of them no need to go into the MED, just listen to my talk 1 hour, then you you can answer all the question, right? So a lot of topic, but that is the core topic that I want you to highlight and try to understand. All the books is there, all the core topic is there, all the tricks and how the question is there. But now we go to the pattern of the question. So this is single best answer, meaning that there will be 3 statements. One is the scenario, one is the other statement is the question related to scenario, and followed by the answer. The answer usually A, B, C, D, only 4 questions. Only one question and with the 4 answer, but all the 4 answer usually more or less the answer is true. That's why single best answer. But some of the questions sometimes it's not that easy for the lecturers to prepare all the single best. You might notice that 1 or 2, 3, or maybe 10, 20 if you are lucky, out of 60 question, the question is not single best, maybe one best answer. We call it OBA, one best answer. OBA meaning that looks like a single best answer, but if you read the question, the statement, and the answer that being given, oh, this is definitely only C is true. The rest A, B, and D is false, right? That is one best answer, right? We will go through after this. For example, Mr. ML, 70 years old man, present to the emergency department with a day history of fever, cough, right-sided thoracic chest pain. His vital signs are as follows. Respiratory rate 30 breath. SpO2 80% under room air. Chest radiography show right lower lobe infiltrate. Which of the following is most likely diagnosis? Is it pneumonia? Is it pulmonary embolism? Is it lung cancer? Is it pneumothorax, for example, right? So the scenario looks like in practical, right, can be true, all of them, right? But based on the scenario, which one is the best? Fever, usually very rare for the pulmonary embolus, lung cancer, pneumothorax, got fever, for example. But of course, in reality, cancer also can present with the low-grade fever, right? Pulmonary embolus as well, one of the presentation can also fever, but not as, common as pneumonia, for example, right? Respiratory rate 30, SpO2, chest X-ray, right, lower lobe infiltrate, right? So most of I think everybody will agree that pneumonia is the best answer for this scenario. For example, this is the question. But for the purpose of the physiology and the pharmacology question in the MEDEX and Anaesthesiology, if you want to know more question after this lecture, you can refer to this website. This is online question that been prepared by one of the lecturers in the USM, Associate Professor Dr. Wan Nazar, I think a lot of question from physiology is there, right? I think you can buy, but not that expensive. I think around 10 ringgit, if I'm not mistaken, right? And you can just access online. A lot of question, because for the purpose of this MEDEX, I'm just try to pinpoint only a few, right? But I can't cover all the topic, right? So that you can just recognize or the pattern of the question. So for example, the first topic that I mentioned previous slide about the cardiovascular topic, for example, right? 5 to 10 question. And among the cardiovascular subtopic that you need to know, cardiac action potential, for example, right? You need to know the resting membrane potential is what is pre-potential, threshold, depolarizing, repolarizing, hyperpolarizing, and then what is the difference between the SA node, for example, right? And the ventricular muscle, right? Which one, for example, don't have the phase 0, for example, right? Which one have phase 0, for example? But if you want to compare, I think more easier, you can look at the comparison table. This is the one that I took from the Carrie Brandis, for example, right? Ventricular SA node, phase 0 rise very rapidly, phase 0 rise slowly, and then the typical duration 200 millisecond, 100, for example. Resting membrane potential in the SA node minus 60, for example, right? And then phase 4, resting membrane potential is stable during phase 4. There is no spontaneous depolarizing, for example, in the ventricular muscle. However, in the SA node cell, whether in the resting membrane potential is unstable during phase 4. So if you look at the phase 4, this is SA node, very unstable, right? Leading to spontaneous depolarizing pre-potential is exists. So this is the a difference, right, between the two drugs, for example. And the clinically can be blocked by verapamil, for example, right? In the SA node, for example. So if you look at the how the resting membrane potential, pre-potential, which is exists in the SA node, sodium intake, right? In phase 4, potassium efflux, for example, right? So you just remember the resting membrane potential minus 80 whenever there is sodium influx, become less negative, then when it reach the threshold potential, then it will fire, right? It will fire the action potential, right? So this is the threshold potential. When the membrane potential reach a certain threshold, maybe minus 40, for example, initially minus 90, sodium influx, then become minus, then it will trigger to the opening of voltage gated calcium channel. Then whenever calcium intake into the cell, right, of the cardiac muscle, then the action potential will become phase 1, phase 2, and then repolarization, for example, right? So pre-potential, pacemaker, spontaneous depolarization is the term used interchangeably, right, for the cardiac action potential, right? So then you can ask whether you really understand or not about the how the impulse transmitted, right, from the SA node, AV node, and then from the endocardium to the epicardium, and then whenever they want to repolarize from the epi to the endocardium, there, right? You can just read this is also from the Carrie Brandis, one of the question that being asked, how is this relevant to AV node? What is the function of fibrous? So there is a fibrous here. For example, this is SA node, travel to AV node. They can't go to here, for example. They need to go to the AV node because there is a fibrous atrioventricular. So between the atrium and ventricle, there's a ring that separated so that the impulse cannot go to the ventricle, right? They need to go to the AV node. Insulation, the function, they provide electrical separation. Structural, the fibrous skeleton provide the structure for the origin and insertion of the myocardial cell, for the insertion of the heart valve. So this is the function of fibrovascular ring, right? Okay, for example, they can just ask, what is the last part of the heart to be depolarized? The answer is posterobasal part of the left ventricle. Epicardial surface is the last, right, of the left ventricular wall at the base of the heart, right? So if you look at this picture. So this is the example of the question that can be asked in the cardiovascular system under action potential or under the cardiac action potential. So they can ask you about the phase 1, phase 0, phase 2, phase 3, or phase 4, for example. Sinoatrial node action potential has few unique characteristics if it is compared to ventricular action potential. Which of the following statement best describe the above action potential? Okay, who want to try? Anyone? Very easy
Hi,
question.
Doctor.
Yeah,
When I try,
yeah,
I think the answer is D, unstable resting member potential at phase 4.
yeah. Everybody, do you agree with the answer D? Anyone want to try difference or really 100% sure that this is D? Right. What about the Suhaila, Yung Tong Chie, right? Jin, Kamarul, Faiz, Hidayatul. Are you sure this is D? Yes, I think the answer is D, right? I think if you read my explanation just now, I think you can just answer easily D, right? Unstable resting membrane potential, right? Describe the above action potential, right? So the answer may be true, rapid depolarization, but with the question unique characteristic, right? This is the unique, right? Compared to the ventricular. Then we move to the section preload, for example, right? You need to understand the definition of the preload, the afterload, the contractility, right? Because this is the core topic, right, in physiology, right? For example, cardiac output equal to heart rate times stroke volume, right? And then the blood pressure equal to cardiac output times the total peripheral resistance. And the heart rate refer to what? The stroke volume is the volume of blood ejected by the left ventricle of the heart, which each contraction, for example, right? And then, for example, if person has resting heart rate 70, stroke volume 70, so the cardiac output is 4.9 liter per minute, right? So if you are maybe 80 here, maybe for 5.2, for example, per liter per minute, right? And what are the factors, for example, that influence your preload? Preload, usually the degree or the stretch or tension in the muscle fiber of the heart ventricle just before they contract, ventricular contraction. So, for example, you imagine this is your heart, the ability to stretch, that is the preload before they contract, right? It is a critical factor that affects the stroke volume. So whenever you have the enough preload, that amount also when you ejected or contract, that is stroke volume, right? Consequently, cardiac output if you time this with the heart rate. So several factors that influence the preload, the blood volume, of course, the total volume blood in the cell system. Patient with hypotension or hypovolemia, of course, the blood volume is low, for example, right? Definitely the preload is low. That's why, for example, dehydrated patient, you try to preload first, right? You give the blood volume, right? You try to give the crystalloid or the colloid or the blood to fill up the volume. And venous return is the flow of the blood from the body's vein back to the heart. Factors that affect the venous return, such as changes in posture or the activity of skeletal muscle size, can alter the preload. valvular function. Remember, if you have mitral or tricuspid problem, the valve disorder may affect the preload. And the heart rate can influence the duration of diastole. A faster heart rate may reduce the diastolic feeding time and consequently the preload. What about the contractility? Sometimes you have the preload. For example, if you have myocardial infarction, for example, right? Inferior myocardial infarction. Inferior meaning that you have problem with the right side of the heart, right? So right coronary, for example. So you cannot give too much of the, for example, fluid, for example, right, to the patient, right, for example, right. Of course, in principle, you give the you can give the preload, right, to the patient, but the right side of the heart is not contract now, right, because of the myocardial infarct, inferior MI, right coronary artery occluded, right. So now the RV is not contracting, right. So in order to generate the enough stroke volume, right, you must combine between the preload and also the contractility, right. So you give the volume, but at the same time, you must also later give the inotropes, right, to contract the right ventricle. But if you don't give the fluid from the beginning, don't give the preload, you just contract empty, for example, right? Because they also already lost their preload, the activity to stretch, right? To stretch the muscle because of the infarct, right? So they don't have the ability. So that's why you need to give the volume, but be careful, and then assist with the contraction. It's different between the left ventricular failure, which LAD infarct, for example, right? Because whenever there is a LAD occlusion, left main stem of the coronary block, they will affect mainly on the left ventricle infarct, right? For example, right? You can't give the fluid too much, but the main thing is that you need to give the inotrope more, because you don't have a problem with the preload because the right side is okay. Venous return can go into the right side and then pump into the pulmonary circulation and goes back to the pulmonary vein, right? So they don't have much a problem with the preload, but with the left ventricular infarct, the problem with the contractility. So that's why you start the inotrope first if you are dealing with the anterior MI, right? Later on, you just need to top up the fluid. But if you are dealing with the inferior MI, for example, right, you need to give the fluid first, fill up the RV first, and then RV, then you can follow by the inotrope later on, right? So that is the, for example, the inherent ability of the heart muscle to contract and generate force during systole, which is the contraction phase of the cardiac cycle. So several factors can influence neurotransmitter or hormone. So if you have the problem with the contractility, that's why in clinical practice, we give the calcium, we start the adrenaline, we start the norepinephrine, right, too strong. Intracellular calcium, sometimes you measure the calcium because as you remember just now, calcium is the main electrolyte during the action potential, right? Sodium influx, potassium influx, calcium influx, right? So this is a very, very important electrolyte. And then the inotropic agent, positive inotropic agents such as digoxin, right? Or negative such as beta blocker if you are dealing with the very hyper or tachycardic, very high heart rate, for example, right? Contractility also can be affected by heart rate. As the heart rate increase during exercise, the duration of diastole phase decrease. This will reduce the diastolic filling time and can affect the contractility. This is a pathological condition of the heart disease such as heart failure, myocardial infarct, right? So if you have failed left ventricle, the last choice is usually patient will die, right? Of course, if you are in the advanced and the center and country, you can have left ventricular assist device. This is just not in your exam, but this is just to give you that we have the palm, right? If you are going to IJN, right, they can just assist you in terms of contractility, right? Mechanically, right? Then what about the afterload? Another section of the cardiovascular. So you have to know what are the factors that can contribute to the afterload. Arterial resistance, for example, there is a very high pressure in the aorta, for example, or very vasoconstriction in the periphery, for example, right? Increased total peripheral resistance, right? So they will be difficult for the forward flow from the left ventricle to be ejected because of the high pressure here, right? So the other reason is aortic pressure. Maybe the patient got the problem with the aorta itself as key component of the or the aortic valve. There is a stenosis there, right? Difficult to pump that. So this is the afterload after the valve or the pressure here, right? So if you have this, they will increase the afterload, right? Vascular compliance refer to the ability of the artery to stretch and expand response to injected blood, right? So the ability, if they very stiff aorta or the vessel, right? So there will be the high increase the afterload, right? Peripheral resistance, such as the systemic excretion, can affect the afterload, such as hypertension can significantly. So high afterload can have several consequences. Increased cardiac workload. So your heart try to pump harder and harder, then at the end they will cause the increased oxygen consumption by the heart, right? Reduce stroke volume because they just can pump maybe a little bit, right? Increase hypertrophy. Prolonged exposure to high afterload can lead to the hypertrophy, thickening of the left ventricular muscle, which can contribute to the heart disease, right? For example, you can imagine this is aortic, normal aortic valve stenosis, right? So much more wider here and narrow here, right? Okay. So lastly, cardiac output. So remember, the cardiac output is a product of stroke volume times heart rate. The size, for example, what is that determine the size of cardiac output at any particular time? The heart as a demand pump, the heart pump blood around circulation happen to demand. It's tissue that demand blood supply and they signal the heart to pump sufficient blood to meet this demand, right? So because the question is that if a healthy subject at rest was given intravenous atropine and heart rate increased rapidly from 60 beat to 120 beat per minute, how much would cardiac output change? So usually no change. The reason is here, right? And you can read the explanation here. The blood flow to each tissue is determined by tissue by adjustment in the arterial tone of the supplying vessel. This is an example of metabolic autoregulation, right? At the end, preload, contractility, afterload, right? This is stroke volume. Influence the stroke volume. Anyone affected, they will affect the stroke volume, right? And then you times the heart rate. If the patient got the bradycardia, sinus bradycardia, for example, cardiac output also become low, right? So cardiac output times the systemic vascular resistance, then the pressure, right? 20-year-old man is planned for elective laparoscopic appendectomy. He has fasted for 18 hours prior to surgery. After induction of anesthesia, her blood pressure is hypotensive. What is the main immediate physiological measure needed to increase the stroke volume for this patient? Anyone want to try?
Increase the preload.
Very easy, right? Increase the preload. Is it true? Yeah, increase the preload, right? So this is, for example, the question that, being asked in the exam. But of course, some of them may be difficult a little bit, but we try not to ask too much difficult question, right? We try to go to the core topic that we highlighted in my previous, earlier slide just now, right? Cardiac cycle, I think I can't teach you every section. If I teach you every section, maybe we will end up 9 p.m. tonight, right? But I will try to go. We have another 1 hour. So this is about the cardiac cycle, for example. It's a series of coordinated mechanical and electrical events that occur during one complete heartbeat. It represents the entire process of the heart. If you remember the ECG, P, Q, R, S, T, for example, right? As it pump the blood through the various chamber and valve of the heart and into the circulation. Whether we realize or not, every second that we breathe now, right? Now our heart is pumping, right? starting from the atrial systole begins, atrial contraction, force the blood into the ventricle, right? From the atrial, force into the ventricle. Then ventricular systole. During this phase, you can see that P wave generated, right? Atrial diastole initially, and then atrial systole, right? And then ventricular systole, first phase, ventricular contraction, push the AV valve to close, atrioventricular, and then they will open the pulmonary, right? So whenever pulmonary valve open, then we call it ventricular systole, second phase now, right? First phase close, and then second phase ejected, right? And then the semilunar valve close, and the blood flow into the atria, ventricular diastole, right? So the blood coming right, and then diastole late, chamber relax, and blood fill ventricle passively, right? So this is ventricular diastole, systole. This is just a quick diagram to represent the cardiac cycle, but more detail you can read the Carey-Brandis. I think they tell you detail about this, right? I think there is 2-3 pages in the Carey-Brandis, very detailed. I think if you understand that 2 pages, very easy you to remember the phase. For example, what happened during atrial systole, isovolumetric contraction, ventricular ejection. For example, what are the phase of systole and the phase of diastole? Indicate, for example, right? Isovolumetric contraction, 0.05 second, for example, right? Isovolumetric, this is the first phase of the systole. It lasts from the mitral valve closure, this is the closure of the mitral valve, until opening of the aortic valve. This is opening of aortic valve. So this is, you can imagine, 0.05 second, right? This is the duration. We call it isovolumetric contraction. And then isotonic contraction, separated into phase and phase of reduced ejection. Prodiastole, this is the last phase of the systole when injection has finished and the pressure start to fall, and then aortic valve close. So this is the thing that you need to go and read detail about this, so that, because this is the cardiac cycle, very important. For example, the question, a cardiac cycle is one complete sequence of ventricular systole and diastole. A heart rate 72 beat per minute. Cardiac cycle takes 0.8 seconds. If the heartbeat is 60 beat per minute, the cardiac cycle takes how many seconds? How many seconds? The student candidate, 72 beat per minute, cardiac cycle 0.8. Let's say your heart rate is 60 only.
1 second.
Yeah, 1 second, right? So you can imagine if your heart rate is 120 beat per minute.
2 seconds.
2 seconds, is it?
120 beat.
So 0.5, right? The more the high the tachycardic you are, the smaller the times, right? But this one also will very dangerous. It will affect the diastole, right? Because whenever you tachycardic, diastole become less, and this will affect your feeling, right? And diastolic feeling. This is the diastasis, reduced feeling. The phase diastole, very important. You need to understand, right? So you must read one by one, read by words, then you will understand, right? Follow slowly the curve, read this statement, right? Because very important when the valve phase of the cycle, isovolumetric relaxation, all the valve close, ventricular filling, AV valve open, isovolumetric contraction, AV valve close, right? So this is the things that you need to understand. I think Carey-Brandis is very easy. If you read word by word detail, you will understand, right? And this is the summary of the more diagram, right? Diastolic phase of cardiac cycle can be divided into few stages. Which stage does contribute the least volume of blood to the ventricle? Anyone want to try?
C.
Atrial contraction. So any other answer? Okay, we don't have much time. Oh, the answer is T. So I think you need to go back to the question and the diagram that I mentioned just now, right? So the question might be different a little bit, but the pattern may be more or less the same, right? So why the isovolumetric ventricular relaxation, which does the least volume of blood to the ventricle, right? Of course, during atrial contraction, there will be a lot of blood, right? Will be enter into the ventricle, right? Because there will be passive and during the diastole and systole, right? Rapid ventricular filling, and then will have, and then slow ventricular filling. So you need to know, right? If you go to the diagram again, right? So isovolumetric ventricular contraction. Following atrial systole, the ventricle begin to contract initially or the valve are closed. Both this phase is called iso because the volume of blood within the ventricle remain constant while pressure is increased. So during this phase, the blood volume just very minimal or constant, right? There is no change, right? So that's why the answer is the D, right? So during the atrial systole, during this phase, atria contracted, pushing the blood into the ventricle. This phase contribute to the filling of the ventricle, right? Yeah, I think this is the answer, right? During diastole, atrial diastole, the atria relax, filled with blood from the vein. This phase prepare the atria for the next cycle, right? Now we move on to the respiratory. I think I need to go faster. We already 1.5 hours. We have another 1 hour, right? So, okay. During the spirometry test, the physician plans to identify the maximal volume of the gas that can be expelled after maximal inspiration. What is the type of lung volume best to describe the above explanation? Anyone? So you need to remember the lung capacity, the vital capacity, FRC, the closing capacity, closing volume, and expiratory reserve volume, inspiratory reserve volume. Whenever two combination of the two volume, then become capacity. 2 or 3 volume combined become capacity, either total or FRC. FRC is the residual plus the expiratory reserve volume, for example, reserve volume, for example, right? So become the FRC, functional residual capacity. Inspiratory reserve volume plus all the FRC plus the ni become, for example, vital capacity, for example, right? So if the question, the maximum volume, so what was the answer?
Vital capacity?
Yeah, vital capacity. Any other answer? Chia? Kumaran?
Vital capacity.
Vital capacity also. Let's see the answer. So vital capacity, right? So the answer is true. So where is the vital capacity? So this is the vital capacity. Why not total lung capacity? Any other reason? Any other reason? It's not logic, right? You have to, expel all the lung, all the air in your lung, right? If you expel all the volume in your lung, right? So the patient might be die, I think, during the procedure, right? So there must be volume inside your lung. So this is, we call it residual volume. This one is I think no way to be expelled, right? So as a human being, we only can expel our reserve volume. We can expel we can measure this, right? Because we can breathe in, we can breathe out, right? We can try to expel everything, right? Until you can expel anymore, then it's vital capacity, right? But still, you cannot expel all. If you expel all, then collapse of your lung, and then you will be, SOB maybe after that, right? So, okay, good. And this is the detail. I think in the Carrie Brandy is very detailed about this. You can have a look and check with the Peter Kam and as well as the Linda Costanzo. If any discrepancy, I think you need to refer to the Peter Kam as the main textbook, right? So total, the volume, residual volume, how much? 50 to 20 mil, right? Inspiratory reserve volume, FRC, 30 mil, right? What is the difference between a volume and capacity? As I mentioned, both represent volume of gas, which is volume is only one. If you combine two, become the capacity. ERV plus RV become the functional residual capacity, right? RV plus the tidal volume plus ERV become vital capacity. Which of this volume and capacity cannot be measured using spirometer? The residual volume. So residual volume and any capacity which contain residual volume. So if you want to measure FRC also cannot, right? Because it consists of the residual volume. The basic problem is that the residual volume stay within the chest and spirometer can only measure gas which is expired from the lung, right? How you define FRC, right? This is FRC, right? So the question also may ask you the question about the how large is the FRC in adult, about 30 ml per kilo. Is nearly fully established within 30 to 60 minutes of birth. A healthy 3.3 kilo unit will have an FRC of 100 ml, right? Because of the 3 kilo times 330, then become 100 ml. What factor affect FRC? I think you need to remember this is your usual practice. You give the anesthesia, right? Increasing the height of the subject, very good. For example, standing and supine. If you can anesthetize patient in standing, I think it will be good, right? Because it will not affect your FRC, right? Changing from supine to erect position, right? Decrease lung, for example, emphysema. So sometimes the good thing about emphysema is that increase FRC, right? But of course, in our usual daily as an anesthetist, you will encounter obesity, then you give the muscle relaxant whenever you want to intubate, and then you supine the patient, and then patient got some more pulmonary disease, right? Such as ERDS or fibrosis, for example, pregnancy, and then anesthesia, all decrease the FRC, right? So FRC, is it affect increasing age? Is it different 60 years old, 90 years old? Does not change much during the age in the absence of condition which alter. So this is the condition, right? So I hope you get a little bit information about FRC. So this is detail more about FRC. I think you can read, right? What is the important FRC? Minimize the VQ mismatch, minimize the pulmonary vascular resistance, minimize word of breathing, help prevent atelectasis, right? Buffer for maintaining steady arterial PaO2, right? So this is a buffer, for example, you pre-oxygenate 3 minutes, right? So 8 minutes, patient will deset, right? Because of the FRC, right? You give 100% oxygen, right? So all the 2 liter or 2000 ml of the volume in your alveoli, you know, will be full with the oxygen. Not in normal condition, you breathe 21% only, right? The rest is nitrogen, right? So if you don't pre-oxygenate, you imagine maybe 1 minute patient will descend, right? But if you pre-oxygenate, because of the oxygen consumption, 250 ml per minute. So 1 minute, 250, 2 minutes, 500 mil loss. 10 minutes, you don't, you know, do the supply of oxygen, you take time to intubate, and patient start to descend, right? But this is provided patient don't have this obesity, pregnancy, for example, right? But if you have this, sometimes that's why when you intubate the patient, you give the mother relation, pregnancy, obesity, then within 1-2 minutes, patient descend, right? Because they will reduce the FRC. The FRC or FRC is no longer 30 ml per kilo. Maybe 20, maybe 10, we don't know, right? So this is very important. Lung compliance is defined as the changes of volume per changes of pressure, and the normal value is 200 ml in the water. What is the possible perioperative condition that might decrease its value? Anyone?
Bronchospasm after intubation, D.
Bronchospasm after intubation. Any other ni? Kumaran? Kumaran want to answer?
Bronchospasm after intubation.
Bronchospasm. Lung compliant is defined as the change of volume pressure, right? So whenever there is a bronchospasm, so pressure high, right? So the volume also low, right? So if you low volume and then the pressure high, maybe you will get the reduce, right? The lung compliant, right? For example, right? So yeah, I think Gary Brandis, you can just have a look, very easy to understand, right? But you must remember the compliant also is called static and dynamic compliant. Static compliant meaning that if you are ventilating the patient and you stop the gas flow, then you measure the compliant, then will be static, right? So you can test on your ventilator in your ICU, right? For example, right? Just have a look the graph, right? So you can measure sometime 10, 20 only for patient with ARDS, right? Normal lung, usually you can see 80 or 70, right? Because that one is the compliant of the total lung compliant, right? So you must understand also the compliant is can be divided into the static and the dynamic compliant. So the volume over the pressure, changing of the volume, changing of the pressure, right? The lung, how distensibility the lung, right? So that is the compliant, right? Oxygen cascade is the stepwise decrement of oxygen tension after the air is inspired from the atmosphere. The tension is decreased at one stage to 149. At what stage of oxygen tension is the best in describing the above condition? So this is, you need to remember the step ladder, right? The stage, right? So anyone want to answer this?
C. At the inspired air oxygen tension without water vapor pressure.
Yes, agree with you, right? So yeah, you need to remember this one, right? The oxygen cascade. You see, for example, if you are breathing now, I ask you to breathe your PaO2 159 by right. But when I measure, why only 149? Because of the saturated air. So you need to minus 47, right? But when you take the EBG, it's actually only, for example, 95, for example, where this is lost, right? So this is the thing that you have to know. Maybe there is another reason why from 149 drop to 95, right? By right should be 149, right? But the result may be only 95 to 100, for example, right? So you have to measure the PaO2 at the alveolar gas, right? So how? This is the formula, PaO2 minus and then you have to minus the CO2 divided by the respiratory equation, right? Gas exchange in alveoli, venous administer. So when you measure in the arterial blood, there is loss another 5 because of the some of the deoxygenated blood go direct into the without being oxygenated, right? So bronchial vein, and you can read a few vein that contribute to the venous administration. So that is why, right? So the question, the alveolar is depending on the balance, oxygen delivery. How would you calculate the alveolar PO2? This is the formula. What is the term F in the above gas equation? Why is the PO2 arterial blood usually slightly lower than alveolar PO2? Because of the venous admixture. This is due to two factors, true shunt and lung unit with the VQ ratio less than 1. Usually a small amount of shunted blood has not passed through the gas action area of the lung and has lower. So some of the blood, they don't go to the lung to be oxygenated. So they bypass and straight away to the arterial system, right? Diffusion oxygen across blood gas membrane is almost never a very oxygen transfer. Does not contribute to normal small value. Okay. What about this question? 50-year-old man represented with acute pulmonary edema. The PCO2 is 35. His pulse oximeter saturation is 80% and improved to 100% on CPAP. Which cause of hypoxemia best explained above statement? Anyone? So this is, they want to test you causes of hypoxemia, right? Some of the causes, for example, you go mountain hiking, for example, Kota Kinabalu mountain, right? So if I can measure your PaO2, for example, because of the inspired oxygen is low there, right? So you will get lower PaO2, right? But there will be a little bit increase in CO2, right? In this case, so B is out already. So either A, C, D, the causes, right?
Ventilation mismatch.
Yeah, I think that is I think the most that I think among the A, C, and D, I think you should consider D. I think the most correct. C is correct. A also is correct, partly correct. But if you talk about the theory, if you talk about the shunt meaning that we are referring that, for example, when there is a very severe pulmonary edema, and that severe pulmonary edema, for example, occlude all the alveoli, right? So the shunt is 100%, for example, right? So whenever this is the lung, right, and then occluded both, and then there is a blood flow, but there will be no gas exchange and all, right? That is true shunt. So whenever the shunt is 100%, for example, you give how much oxygen pun, usually there will be no improve in SpO2, right? But in our daily practice, right, basically there will be a minimal shunt, but the other lung also still perfuse, and then ventilation is okay. So that's why in overall we say that ventilation and perfusion is matched. There is a ventilation a little bit, but not matched with the perfusion. That's why when you give the oxygen, they will improve because you increase the oxygen on the other part of the lung, then maybe it will help you to improve the SpO2, right? I hope you understand. So the scenario can be changed, and then maybe the answer is shunt. For example, his blood pressure solution 80% in room air. However, after giving 100% oxygen, the SpO2 still maintaining 80%. So if the question is like that, the answer should be?
The answer should be shunt.
Shunt. Yeah, so shunt. So remember, shunt, how many percent oxygen you top up, even 100%. If it is true shunt, I mean 100% shunt, usually there will be no improve in your SpO2. For example, a patient with very bad ERDS, that very bad, you know, no matter you try to ventilate, and there will be no blood, you know, can be exchanged, right? Because of course, ARDS is not only shunt, right? A few things, diffusion, right? But of course, just imagine that you just occlude foreign body on the trachea, right? So no flow to the lung. Okay, this is the west zone. I think I don't have much time to explain, but you just remember this is your lung in the erect position, in the apex, in the middle, in the vessel, right? Pressure in the alveoli, this is your alveoli, higher, right? So that's why they compress the pulmonary artery and then the pulmonary vein, right? So there will be, you know, the flow is not that great compared to the part of the lung at the vessel, where the pressure in the artery is much more bigger compared to the venous, compared to the alveoli. So the flow can go very easily, right? Compared to the zone 1, zone 2, and zone 3. But in zone 2, a little bit different. Yeah, arterial pressure is higher, but higher than alveoli only, but alveoli still higher than the venous, right? So this is the west zone. So I think you need to read a little bit about west zone. I think the best is Chevy West. I think there will be one question from the west zone, from the what we call the surfactant, right? So regarding the respiratory, as I mentioned in the core topic, but I can't give you all the example because we don't have. Okay, renal, the kidney is mainly supplied by the renal artery. What is the true statement to describe its blood flow to the kidney?
A.
A. So the answer is B. Is it 50%? Tak ada output? Or 20%?
It's 25%.
25%, right? So that is A is wrong. So sometimes the number also, sometimes this is, as I said before, this is the one best answer. It's not single best, right? So the rest usually wrong, right? So that's why the answer clearly B, right? For example, right? So please have a look. Yeah, just very, very simple, topic for the renal. Sometimes they can just ask you like that. The filtration at the glomerulus is important in the formation of the urine. What is the main factor that affect the filtration? Main factor.
Hydrostatic pressure of the capillary.
Hydrostatic pressure of the capillaries. Okay. True, right. So this one also, I think you can just make your own note, right? I think in the Peter Kam, and the Carrie Brandis, I think not much, but Linda Costanzo, I think you can read, right? Aldosterone is product of the renin agency system. Which, what is the untrue statement of it? So this is also one best answer. So it's not the single best, right? Meaning that maybe only one is true, right? For example, this is the, I think most of your question, because we try to make it easy. So if we do all the single best, I think you will very difficult for you to answer. So I think there will be mix of the one best and single best. But in general, we will produce the single best answer, a single best question. But of course, during the process, some of them may be one best only, right? What is untrue?
D.
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 Yeah. So it causes water retention. Untrue statement of it. Okay, I think you need to try to go and check, right? 20-year-old man has a traumatic brain injury with subdural hemorrhage. What is the first compensatory response of the brain to the above condition? This one looks like SBA, right? Looks like all the process happening, right? But which one is the most first? Is it herniate the brain? If herniate the brain, of course, patient will die, right? So unlikely. Translocation. Okay. I was yeah.
C. Oh,
A, the answer. So I think you can read the Carrie Brandis. I think got this information. Peter Kam also. So yeah, this is the Carrie Brandis, right? Cerebral blood flow has an auto-regulation response to blood pressure changes. What is the best statement to describe the function of this mechanism? Any answer?
D.
Okay, D. Blood-brain barrier is special barrier that protecting the brain between the cerebral blood vessel and blood-brain parenchyma. What substrate can pass through it with
A.
a specific transport mechanism? Okay, good. So you must prepare all this, right? Okay, I think that's all for the physiology, 30 question, but I don't cover all, right? So we move on to the pharmacology question. We have 20 more slides, right? I think we will try to finish for 30, right? 2.5 hours. 40-year-old male is given IV midazolam 5 milligram and propofol, right? I think this is the usual drug that we give, right? Sometime, right? It's not usual to combine both, right? So if you combine both, significant hypnotic effect which is greater than the expected combined effect of the drug. Which of the following best describe this interaction?
D. Synergism.
Synergism. Synergism. Any other answer? Okay, true. 20-year-old woman presented with hemorrhagic shock secondary to bilateral open femur and tibial fracture. The vital signs are as follows. He is scheduled for emergency operation. What would be the best IV induction agent to induce this patient?
B. Ketamine.
Ketamine. Yeah, I think everyone agree, right? If you have BP low, but of course heart rate is a little bit high, right? Some of you may want to try other drug, but of course maybe ketamine is the best, right, for this condition. Propofol is used for induction of general anesthesia in 20-year-old men. Which of the following mechanism best describe the above drug? This is the one that I mentioned just now, right? So they can ask you propofol, they can ask you the thiopentone, ketamine, right? Midazolam, right? Maybe for this exercise, I give example propofol. In the exam, maybe ketamine, thiopentone, I don't know, right? Or the mechanism of the scoline, rocuronium, sevoflurane, right?
A.
A, any other answer?
D.
B, activate. So
D.
D. Okay, so you see or not, the question is just maybe activate, mimic, right? That's why I want you to read the stotin and try to make your own note to differentiate between the 5 anesthetic drug, right? So the answer is A, right? Increase channel opening, so allowing for increased chloride entry. Maybe there is a wrong between the mimic, activate, right? They should be inhibit, right? Not activate, right? For example, right? Enhance, for example. Inhale anesthetic. 50-year-old man present with sign of increased intracranial pressure following a motor vehicle accident. He is planned for craniotomy and evacuation of subdural hematoma. Which of the following inhaled anesthetic agent is the most suitable for the maintenance of anesthesia?
Sevoflurane.
Sevoflurane, is it? Agree? Yeah, sevoflurane, right. So the scenario can be for halothane, amphoterine, or desflurane, right? So for example, tension scenario for obese patient, right? So which one is more suitable to be used? So if the scenario is obese patient for bariatric surgery, right? And then the most suitable, I think, desflurane, right? For to be used, right? Inhale, the odorless inhaled agent has the following properties. This is the pharmacokinetic. So as I mentioned just now, SIBO, nitrous oxide, one more, right? You have to remember, right? And the xenon as well, which is the very rare, we don't have, right? But non-oil gas partition coefficient, only 1.9. Blood gas, very, very less soluble, 0.14. So you must remember SIBO 0. How much the blood gas partition coefficient? 0.4 or 0.6, 0.4. Nitrous, how much? You don't know. MAC, boiling point, non-irritant airway, is not metabolized. Most of our drug is metabolized, right? But this is not metabolized, right? So which one?
Xenon.
Xenon.
Yeah.
Xenon.
Analgesic, 50-year-old man with end-stage kidney disease is involved in road traffic accident and has sustained flare segment rib fracture. Which are the most appropriate analgesic as a multimodal analgesia? You need to choose a very, strong opioid, right? Segment rib fracture here, right? So you are either choosing A or D, for example, right? In this case, right? So
Fentanyl.
yeah, end-stage kidney, and then you have to choose the kidney. 41-year-old man present with anterior cruciate ligament repair as daycare surgery. He refused the option of general anesthesia but agreed to spinal anesthesia. The expected duration is 3 hours, 4 hours. Which of the following is the most appropriate local anesthetic?
Ubivacaine.
Bupivacaine, yes, because MAPI is very short acting, right? Lidocaine also short acting, right? Prilocaine is not commonly used and also not the long acting one. Specialist plan to perform awake fiber optic intubation for a patient for difficult airway. He applied cocaine. What is the property of cocaine that make it suitable in this case? Cocaine is ester. Why we give cocaine to the nose prior to fiber optic?
D. It produced localized vessel constriction.
Yes, true. D. 54-year-old man with indwelling lumbar epidural catheter in situ following laparotomy cystectomy. She developed local toxicity after immunization of a 10 ml bolus of 0.25% bupivacaine. What is the earliest symptom of LDA toxicity?
C.
Yeah, agree, C. 35-year-old man brought to the emergency department with the severe hypoxemic respiratory failure due to pneumonia. She required immediate tracheal intubation. Which of the following muscle relaxant is the best choice for rapid sequence induction in this patient?
C. Saxamethonium.
So the question might change to the rocuronium. For example, if I give this scenario and then patient had a traumatic brain injury, for example.
Rocuronium.
Yeah, you have to choose maybe rocuronium, right? So that is the rocuronium high dose, right? With the all the difficult airway and the reversal sugar MEDEX standby just in case, right? Muscle relaxant during elective general anesthesia procedure, intravenous arterocurium with neuromuscular monitoring. At the end of the procedure, you plan to use nexigmin to reverse. When is the best timing for administration of reversal agent? A and C is wrong because you can't reverse. You can't reverse whenever patient train off for 0, train off for 1, or whenever patient in deep block or in intense block, right? So the answer?
B. B. Train of count of 2.
This is the best timing. The best timing meaning that you have option B and D. So if you were given chance to reverse those who are already top 2 and top 4, which one should be the best? Should be D lah. Of course, the earlier, if I say when is the earlier timing to reverse, then the answer should be B. So the earlier that you can reverse, right? But if you have 2 and 3, then you can choose 2 or 3. You will choose 3, right? Right. The best timing, of course. Are you practicing reversing at train of 4-2? No, right? So most of the time, whenever you want to reverse, patient is already, spontaneous. Whenever patient is spontaneous, usually patient is already maybe just 5 to 10% only block the receptor, right? So train of 4 already maybe 4 at that time, right? Yeah. But if you don't have the answer 4 here, let's say this is the maybe PTC1 or whatever, so the answer is B, right? So this is the depth of block, right? Remember. Complete block meaning that whenever you give muscle relaxant, just 5 minutes, 3 minutes during your intubation, should be the TOF 0 and the PTC also 0, right? And a few minutes later, when you do the TOF count and post-tetanic count, TOF still 0, but PTC start to appear, right? There will be a certain simulation already to the your thumb or your fingers, for example, right? Start moving, for example. Moderate meaning that TOF count there is a 1 to 3. TOF 4 can be further divided into TOF ratio, whether 0.4 shallow, TOF 4 0.8 to 0.4 minimal. Educate meaning that you can extubate if the ratio is 0.9, right? So you can see this. For the patient with the microsurgery, you try to maintain PTC 0. No, TOF 0, but PTC 1 to 2, for example, right? Musculoskeletal operation, orthopedic, maybe you can accept PTC 3, 4, 5, right? Maybe the patient start to enter into TOF count 1, right? TOF count 1, you need to top up already, right? 1 to 3 need to top up, right? For the continue the muscle relaxation, right? But to reverse, you need to as early as TOF 2 you can reverse, right? If you want to reverse, right? As late as depend. Sometimes you reverse at TOF 4, right? You reverse at TOF 0. TOF ratio is TOF 4 and TOF ratio already 0.4. You still reverse, right? And even TOF 0.9 you still reverse, right? You don't believe into the monitoring, right? You want to reverse, but no reversal at TOF 1 and 0, right? The earlier if TOF 2, but the best time depend. If you have two option between 2 and 3, I would choose the TOF 3, the best, right? The best time for me to reverse, right? Okay, thank you very much. 2 hours almost. The MEDEX preparation exam, and hopefully you learn something, and I'm going to highlight again. This is the core topics, right? To summarize, please prepare yourself: cardiovascular, respiratory, renal, central venous system, and pharmacology among the 5 core topics, right? Anesthetic, inhale, analgesic, LA, muscle relaxant, neuromuscular blocking agents. I think this is the textbook that you want to read, right? And regarding the system, I think you can go one by one. I'm already touched cardiac potential, cardiac cycle prelude, but the other 3 not. I don't have enough time. I'm touched about the lung volume, a little bit west zone, causes hypoxemia, compliant, right? Oxygen cascade, right? You can read about the west zone, right? Pulmonary factor. Maybe the one question west zone, one question hypoxemia. Usually hypoxemia, they will test you about the shunt, ventilation, perfusion, right? But remember, through shunt, usually cannot be corrected with 100% oxygen, right? And yeah, renal, yeah, this is the central nervous system. Okay, that's all. Any question or tips from all of you? You want to know? I can try my best to facilitate you. I mean to help you in preparing. And maybe before I open to you, how many of you already have the books that I mentioned just now? Don't have yet, right? So I think you need to have that books, right? And try to make your own notes, right? Try reading 3 to 5 books that I mentioned just now, and then you try to compare all the core topics that I'm given you today, right? Then you can try to go to the Dr. Wan Nazar question for physiology, right? For the pharmacology, I think you can just read the topic that I give you here, and try to go about the pharmacokinetic, pharmacodynamic, cardiovascular effect, right? Cardiovascular effect and the respiratory effect, right? Okay. Is it difficult? Chia, is it difficult? What is your opinion? If this is the topic, I think fair.
I think it's fair.
Yeah, I think it's a fair compared to previous time. I think we don't have this, so we don't know when to read, right? We just read the whole book, right? So we don't have focus, right? So now you should have a focus, right? So you can spend maybe 1 month. I think you can finish read about this, right? I think maybe one day you go through one topic, right? And then the other day IV anesthetic agent, and then after 10 days you finish, then you go second round, third round, right? Then try to make your own note. It's not just reading and then leave it, right? You read 3 to 4 books and then you make a table. For example, IV anesthetic agent. Got 5 just now. You make a table, mida, thiopentone, ketamine. And then the second row, you make it the A, absorption, metabolism, excretion, right? And then cardiovascular effect, respiratory effect. The same thing also for inhale. You put the sevoflurane, isoflurane, halotane, xenon, and then you remember all the blood gas, everything, right? So very easy for you to handle if come out in the exam, right? The same thing also for the LA, the muscle relaxant. Just choose the rocuronium. You must know rocuronium very detailed, and then the atracurium. This is the 2 drug that you use every day, right? Muscle reversal, neostigmine, you must know atropine, and the sugammadex, right? The commonly drug that you use every day, right? So make your own notes regarding this factor that increase the onset and offset, right, of inhaled anesthetic agent. So just now, you open 100%, 8%, and then you increase the flow, you minimize the circuit leak, right? And then try to use the short circuit if you have a chance, right? Because faster to reach the alveoli. And then when it reach the alveoli, you try to minimize the inhalation to be absorbed to the circulation. Try to choose the least soluble, right? So the least soluble, for example, sevoflurane, for example, if you have sevo and halotane more soluble, right? So it takes time to be ready, I mean, to get the onset, right, compared to the sevo, right? Whenever enter into the circulation, and then you got the option, patient with hypotensive or normal blood pressure. So which one will cause more faster? Of course, the one with the low blood pressure. That's why in low blood pressure, you don't give much, right? If not, cause more hypotension, right? For example, right? And then analgesic, yeah, opioid, I already touched just now, right? LA, yeah, remember a little bit about maybe the difference between ester amide and then the example, right? Yeah. Such as EMBLA, euthanasia, right? This is commonly given. And then the hemoglobinuria, right? One of the side effect of the ester, right? Whenever they metabolize, right? Okay. What about the Kumaran? Are you ready?
Yeah, more or
Yeah.
less.
Yeah, I think you should try your best, and then try to get the textbook that I mentioned just now, and then make your own note regarding the topics, right? Cardiovascular action potential, right? Cardiac cycle, right? I think all in the books. I think you can just focus and try to read words by words, right? Don't just read like you reading textbook, like you reading the storybook, right? And so try to analyze, right? And then after you make the question, and then try to gather a few possible question in the cardiovascular. I think you can go to the FRCA. I think FRCA is free if you want to search for the question, right? FRCA, and then you can, of course, the FRCA is part 1 punya question, but still you can just rough idea, right? What was the question all around, right? Or if you want to buy, I think BMJ you need to buy lah. I think about 200, 300 atau ringgit per 1 month. I think the question, right? From that, right? So another option, right? For the pharmacology. Okay, I think almost 2 hours and 15 minutes, right? Any question or anything that how many of you read the JB West respiratory physiology? Do you have all the books? If you don't have, please, this is the key lah. The key books for the pharmacology. Please read the starting. All the IV anesthetic, inhalation, the detail about each of the drug, right? The one that you use commonly, morphine, fentanyl, explained in this textbook, right? So please read this textbook and try to make your own note. I'm sure you can answer in the exam, right? All the questions usually come up from this book, usually, right? But we try to make it very simple, not as part 1 or the final year question, right? Sometimes can be overlap, but the answer usually very straightforward, right? Compared to the part 1. But we need to make it difficult a little bit, because if we make it easy, so everybody got 100%. So, no competition at all, right? So sometimes we need to make it a little bit difficult, right? Maybe not that difficult compared to the part 1, right? But if you ask me the border or the boundary between the part 1 and the entrance, I can really answer that question. But the question for the part 1 is much more difficult than the question that I show you just now. It's not. The question in the part 1 usually very, very detailed a little bit, right? Sometimes very rare drug also being included in the option, right? Okay, I hope 17 of you can pass all the MEDEX, and 17 of you will joining us next year, right? Do you know when was the exam, Faiz, Kamarul?
1 November.
1 November, so 1st November, so another almost 1 month, right? I think you got time, still got time. So those who are in USM, maybe you can if you don't understand the concept or everything, you can just see me in my room, or maybe you want to have a question or anything. Those who are outside USM, if you want to ask, just email me, right? I can just answer to you, but try to search the question, the answer usually for the facts, usually all in the books now, right? But for the understanding, I can try my best to teach you, right? Especially pharmacology and physiology also, I can try. Any?
Sorry,
Yeah.
Doctor. I just want to ask regarding this exam. They will be conduct via online. Compare with the face-to-face and online, what difficulty that we might encounter during answering the answer? Sebab according to the previous exam yang online, some candidates said after we answer the question, they cannot go back. So is that maknanya after answer that question, we must ensure that the answer really
Yeah.
finalized lah.
Yeah, that is uh, uh, the previous exam, right? I think this is the third time. The first time in USM, is it? Yeah, USM. And then follow, I can remember last year, right? And this year UBM, right? The host for the exam, right? So how many hours the time given? You remember or not?
90 minutes.
So you only got 1 minute 30 seconds for each question, right? So remember that don't spend too much time. You must strategize, right? So you set your time. Okay, already 1 minute, you have to move on, right? Maybe 1 minute 15 seconds, then you move on, right? And then please make sure 1 minute is the first, and then another 50 seconds to think about the whether this is true or not, right? So I would agree with you. Be prepared that you can't reverse, right? But if you can reverse, then it's good for you. But that one is depend on the host, right? So we can really know whether the system for this time is already upgradable or not, right? Last time, yes, you can't reverse, right? But for this time, I can answer whether you can reverse or not. But be prepared for you know, be ready that you are not, you can reverse, right? If you can reverse, it's a bonus for you, right? Because it's not that easy for online. We also try our best, I mean the host, right, to improve year by year, right? So as a tip, I think if that a case, right, read the question carefully word by word. Sometimes you miss the keyword, right? So the keyword, right? But I think not that difficult compared to the part one that, you know, word by word you have to read. But still, right? Don't make a mistake between the, I mean the just because of the statement correct, incorrect, right? You miss, right? You miss the answer, right? So I'm so sorry, Faiz, I can't answer for ni, but I will try to answer. I will try to ask the host, right, whether they for this time whether can be reversed or not the previous answer and question, right? Whenever you enter, right? So what are the what we call the application that they use, right? This time, right? Okay, any more question? So yeah, 1 minute 30 seconds, right? So remember for 60 SBA, single best answer. So how many of you already prepare? I mean, already read the books before joining the session today. I mean, already read, maybe already strategize, right? How many of you, Chia, already prepare?
They're still preparing. I'm still preparing.
Yeah, good. Kamarul?
In preparation, in progress.
Yeah, good. In progress, right? Pak Is, Hidayatul, Hidayatul and Suhaila, is it? Or you just try by chance? Okay, I want to sit the exam and just try a chance, right? I think if you do like that, you will fail lah, most of the time because I mean compared to the others, right? They read, right? Unless you are genius lah. If you are genius, super genius, then that one is no question lah. You just read once, then you can remember, right? But normal, ordinary, I think candidate, they need to, you know, go words by words, read, right?
So I have question, Doctor.
Yeah.
I actually finished already the physiology. Now I'm spending 2 weeks for pharmacology, and then another 2 weeks I was thinking for question, to answer question lah. So what do you think? I mean, is it for
Is
me
it
to
the best? Is it the best strategy, right?
yeah, I don't know. Is it better for me to focus on the theory and then just few days for the answer the question, or you or how?
Yeah, I think there is no right and wrong, right? For me, each individual have a different approach, right? If you think that works for you, right? Yeah, go ahead. But remember that the one that you read 2-3 weeks ago or already 1 month, make sure that you don't just leave it there, right? Even though you are reading the pharmacology, but you must spend also every day the one that you read previously. Try to try to recap back, try to story to your friends, right? The best thing is whenever you are in OT or in on-call, for example, you just ask your new colleague, houseman, right? Force them to listen to your your lecture. Right. You try to try to teach them lah indirectly, right? And then try to exercise, right? I think that is the way. And then along the way, you try to make it a question, right? So you try. For me, you try. For example, I already give you the core topic. You try to search as much as question from the core topic that I mentioned just now. So for example, question regarding rocuronium, you try, you search in all the question that you have, bank question or whatever, right? 10 question about the rocuronium, 10 question about the scoline, 10 question about the bupivacaine LA, 10 question about the compliant, 10 question about the west of zone, 10 question about the cardiac cycle, 10 question about the CSF, right? So you try minimum 10 questions. So 600 questions minimum you have to do. So if you want to be confident, that is my my suggestion, right? So if you go that way, I think you will know whether you are covering enough or not, right? So I'm just giving you one question, right, for each of the core topic, right? But you try to search another 10 scenario, right? And I think you will have a better understanding and better to remember and better to answer in the exam. So try to search for that is I think the best way for me, right? Rather than you just read, right? So you read all and then after that finish cardiac cycle, already understand, try to look at 10 questions about the cardiac cycle SBA. That approach, right? Read about the preload, afterload, try to get the question about that. About French Starling, try to look question about that. About the surfactant, try to look about the 10 question, possible question of surfactant. So I think that is the best. If you can get the previous year question, then would be better. But I think previous year, there will not be disclosed, I think, to all the students, right? Because the question sometimes being recycled or being adjust, right? So try to so at the end, if you don't have, try to read word by word in the core topic that I given you. For example, in the Stolting page scoline. So there is a one paragraph of scoline. So you underline word by word and then you translate into your own notes, right? Your own note and about the scoline, and then you list everything. This is Stolting, and then you read TEPAD or this is TEPAD notes, right? I mean the one that's similar you don't have to put lah. The one that different then you put, right? So that in the Miller Morgan Mikael, if you have time, you can read and then you can put a little bit note about the scoline. About the rocuronium, for example, this one, right? Muscle relaxant, if you don't know scoline and rocuronium, I think you can't take for the entrance lah, right? So that is the two drug that being used, right? Like bupivacaine, lignocaine for the LA, right? For example, right? Okay. Please read very hard. Very smart, right? And then strategize your works. I'm sure you can answer if you prepare very well, right? It's just that, for example, some of the question may be a little bit tricky. For example, shunt, VQ mismatch, right? Overlapping, right? The answer, right? It can be VQ, can be shunt also true, right? But true single best, very true SBA question, very difficult for the student if we really do the SBA question. But I think this time, if not mistaken, and the previous time, for the entrance, a lot of combination with the one best answer. One best meaning that among the four, one only true, right? The rest is false, right? That is one best answer. But we try to make it all the single best, but difficult for you lah, right? If we okay, so make sure my approach, my advice, make sure you are in the LAN, if online, make sure you are in the hospital or in the institution that use the LAN Wi-Fi, not use the Wi-Fi during the exam, right? Because sometimes hanging and then problem and then internet, for example, interrupted, right? So try to be in the office or government office, right? That usually the connection is stable. And I would recommend use the direct LAN rather than the Wi-Fi, right? Otherwise you will be, jam, panic during the exam, So one or two candidate also sometimes, I think, enter late and then unable to, I think during the last 2 years in USM, if I'm not mistaken. I'm not the one that handled, but I can hear from the feedback, right? Yeah. So I hope this time you prepare for the best lah, right? Try to be in the good internet since this is online, right?
Doctor, is there any repercussions if, let's say, you get kicked out from Wi-Fi ke, or you come late ke?
Yeah, I think that one you need to clarify with the host, right? For example, before you joining or maybe during the registration, I think you need to email the host, for example, right? Ask them a few questions because sometimes we try to help, but sometimes whenever online we cannot go back because the rest already, sail through, or right, we cannot stop and then just for you, right? That is the problem, right? And then to be, I mean, repeat again, I think it's not fair for the rest already answer, right? You have a chance to, that is so that's why I think you try to be in the best condition, right? Try to be in the best place, right? Try to avoid all thing, right? And hopefully, minimal interruption, right? If you have the interruption, but you still can still, I mean, catch up with the others, right? So, okay. Any more last 2 minutes question before we end our session? Hopefully all of you, 17 of you, 17, right? 17 or 20 of you or 18 of you can pass the MEDEX, and all the carry forward mark also very high, right? So that combination will be enough for you to be in top 120 or top 100 for the next intake. I think if you are success, you will see us in 1st June 2024, right? 2024 lah. Either UKM. If you are in USM in campus, I think USM usually 27 we enroll out of 120. So 27, maybe 7 of you will be in campus usually, but that's depend on the rule of the KKM, right? Sometimes. So 7 will be in campus, right? So you will see us and me as a lecturer in USM, and I think 30 to 40 maybe in right? UKM maybe the same number as USM. So yeah, subscription based, up to date. You can see in the chat, right? My MEDEX Academy. I think very expensive, about 1,000 if I'm not mistaken, up to date, if I can remember. So in the university, some university log in for the students, some not, right? So very expensive, but up to date you can just type all is there, right? If you don't understand, right? But I think you can replace with ChatGPT also. You have to log in, right? I mean, you have to register if I'm not mistaken, right? For the unlimited, right? Yeah. So very good. I think Okay, I think that's all. If you do have a question, you can just email me, right? This is my email, right? I can try my best to answer, right? Especially pharmacology, principle of pharmacology topic lah. Regarding the physiology also, I can answer for you. If you have a question, just email me whenever you are reading, right? For example, right, the books or the question, right? I can give my opinion via the email. You just drop out your question, your scenario, then we can discuss, right? Okay.
Thank you, Doctor, for the amazing
Okay.
talk.
Thank you.
It was indeed
Thank you,
very
Doctor.
informative
Thank
and
you.
inspiring.
Thank
I
you.
must
Yeah.
say, our
Thank you.
participants have
Thank
gained
you.
so much and have more confidence which to study in order to pass MEDEX NS. I hope you all join today will pass with flying colors and becoming the next anesthesiologist. Amin. We will be sending you the recording so that you can do your revision next week. Until we meet again, good luck and all the best for your MEDEX. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Doctor.
Okay. Thank you.
Oh, ambil gambar sekejap boleh? Can you guys?
Okay. Okay. Boleh. Okay.
Yes. Video so that we can snap for today's session. All right. Okay. Screen. 1, 2, 3. One more time. Next page. 1, 2, 3. Okay. Thank you, guys.
Okay. Bye.
Assalamualaikum.
Thank you, Doctor. Thank you all.
Thank you, everyone. All the best. Bye.